we're going to first hear from Susan Bergman. We're going to hear from Megan and Olivia, the dietitians from Spaulding, and then we'll have a couple of panelists that will be sharing a little bit about their bowel routines and how they've been successful. And as you'll see, there are many
Looks
different
like
ways.
they might open up.
Oops, sorry, for people to manage healthy bowels. Okay. I think that's all. I think we are ready to go, and we will hold all questions until the end. If you have a question that you want to just remember or make sure that it's answered, you can go ahead and put it in the chat. And also, if you don't think that we have your contact information and you would like us to have it, you can also directly message me in the chat as well, and give me your email address if you would like to receive our newsletter and so forth. Okay, thank you. So Susan.
Okay.
I'd like to introduce Dr. Susan Bergman. Okay.
Thanks. Thank you, everybody.
Yeah.
Thanks, Heidi. And thank you, everybody, for joining us today. I'm going to try to share my screen and then start the slideshow. Oops. Play from start. Okay. Not sure how to. Okay. Okay, can you still hear?
Yes.
Can you still hear?
Yes,
okay,
yes,
awesome. Awesome, thank you. Okay, this morning we're going to talk about how to maintain bowel health after spinal cord injury. And I really want to thank the GBS SCI discussion group for inspiring this. Oops. Oh, come on. I don't know why this isn't. Oh, there we go. Okay. Going can be hard to talk about, but like many health matters, it really helps to bring it out into the open. Without our digestive system, we wouldn't have any fuel to support the chemical reactions that keep us alive. But some of us have a harder time pooping than others. Most, if not all, people with spinal cord injury or spinal cord disease have difficulty with their bowels. This is because the spinal cord carries messages in real time between the brain and the rest of the body. If the communication is altered, the messages become garbled and open to misinterpretation. This stems from the way the digestive system is laid out and how the different pieces work together. As you'll see,
Susan, are you, oh, okay.
there, okay, I'm not sure what I did, but as you're going to see, the job of digestion is complicated. So understanding the system design gives us clues about how to make things work when the going gets tough. I'm going to cover the typical structure and function of the GI tract, how it changes after spinal cord injury, how to work around these changes so you can live your life, and specific routines and how to build one that works for you. After SCI, food takes longer to travel through the system. With slower transit, more fluid gets absorbed, so the stool becomes drier and stickier and might form a plug. So your digestive tract might not empty properly. It might overflow or just empty unexpectedly. And here is where the physical and emotional concerns become intertwined. Having to think about the possibility of accidents makes it harder and less satisfying to be out in public. My favorite GI tract analogy is the conveyor belt in Lucy's Chocolate Factory. Food travels from one station to the next. Each stop changes the product in some way, but it's more complicated than that, with lots of moving parts, lots of stations. It looks really confusing at first, and it's a balancing act with many adjustments taking place at the same time. The job of the GI tract is to absorb nutrients from food and get rid of waste products. Your digestive system moves food and liquid through your GI tract, breaks it up into smaller parts, sorts the parts into either nutrients or waste, and then moves them on to the next station. Once the parts are small enough, your body can absorb the ones it needs into the bloodstream, where they're transported where they're needed. The rest is stored until it's time to empty. Nerves and hormones work in concert to control the digestive process so that everything works together. The GI tract is a closed, hollow tube with different pathways and compartments. Each area is specially adapted to its unique function, and additional structures contribute specific materials needed for digestion. Your mouth mechanically and chemically processes food with the help of your teeth, salivary glands, and the beneficial bacteria. Your esophagus runs parallel to the trachea and conducts food from the mouth to the stomach. Specially adapted muscles keep food particles out of your airway and keep stomach acid from getting into unprotected areas. In the stomach, acids and enzymes break down food further chemically. The stomach has a special lining so that digestive acids don't break down its own delicate tissue. Sphincter muscles are gate-like rings of muscle that open and close at specific times. They're located at the entry and exit points to each station and regulate the passage of fluids. They keep the stations distinct from one another so that each can do its job. There are 6 separate sphincters in the digestive system alone. Food moves through your GI tract by a process called peristalsis. The muscles behind the food bolus contract and squeeze it forward, while the muscles in front of it relax to let it get through. Sphincters act like gates, opening and closing so that things flow in the right direction. By the time the food reaches the small intestine, it has already been broken up and mashed into a liquid. The large hollow intestines contain concentric layers of muscle that enables their walls to move. An independent backup nervous system, known as the enteric nervous system, lies in between the muscle layers. These localized nerves allow the smooth muscle intestinal walls to move food even without instructions from the central nervous system, sort of like a backup generator in a power failure. There are also inner layers of folds that increase the surface area for absorption. The small intestine produces mucus to lubricate the food bolus. It also houses the immune system cells, or some immune system cells, and maintains the balance of bacteria to aid digestion. It's usually between 22 and 25 feet long, and it's folded to fit inside the abdomen. The large intestine is a muscular tube about 6 feet long, surrounds the small intestine, and continues the process of transporting and converting food into stool. Its immune cells and microbiome, which are the bacteria, are in place because the digestive tract is the main port of entry for lots of different pathogens. The rectum stores stool for evacuation later. The anal sphincter regulates the process of pooping. It's actually 2 muscles, the internal anal sphincter, which is made of smooth muscle and is controlled involuntarily through the autonomic nervous system, and the external sphincter, which is skeletal muscle under voluntary control through the somatic nervous system. It's also part of the pelvic floor muscles, so people can tighten them and loosen them voluntarily if they're neurologically typical. The digestive system receives input from different pathways of the nervous system, including motor, sensory, and autonomic. This information keeps track of where the bolus is and where it needs to go. And that way, opposing muscle groups can contract or relax at different times so they're not working against each other. Gut bacteria in the microbiome also keep things balanced, but the bacterial populations can change in response to antibiotics. Hormones, the microbiome, and nerves pass signals back and forth between your GI tract and your brain. the nerve pathways connect your central nervous system to your digestive system. For example, when you see or smell food, your brain sends a signal that causes your salivary glands to make your mouth water and prepare you to eat. Similarly, when food stretches the walls of your GI tract, the nerves of your enteric nervous system release different substances that either speed up or delay the movement of food and the production of digestive juices. These signals control the action of your gut so that the muscles keep things moving forward. Like a symphony, everything has to be coordinated so that what's needed is available at the right place and at the right time. The coordination happens at the level of the spinal cord, so an injury to the spinal cord will upset the balance of the whole system, and this is known as neurogenic bowel. Without the right conductor, an orchestra just makes a lot of noise. And that's another good way to think about what happens after spinal cord injury. When the conductor's instructions don't get through, no one really knows what to do. So anybody who's able just does their own thing. So now what? What can be done to manage neurogenic bowel? Like all things SCI, you have to forget about autopilot and learn instrument flying. It's not easy, but it is possible, and practice makes perfect. So we start with the fundamentals and go from there. The typical symptoms of neurogenic bowel include bloating, nausea, and the kinds of abdominal distress we're all familiar with, plus constipation, incontinence, bleeding, hemorrhoids, and pain. But in addition to these, people with spinal cord injury can also have more subtle symptoms like increased spasticity or neuropathic pain, either in the abdomen or even in the limbs. And they can also have symptoms of autonomic dysreflexia, which can be pretty dangerous if it's not stopped. You might feel pain, but not where you expect it to be. And it might be very hard to connect pain in your arms with problems in the abdomen or pelvis. Autonomic dysreflexia is usually seen only in people with spinal cord injuries above T6. But even people with lower injuries, lower levels rather, of SCI can experience some fight or flight symptoms like flushing, lightheadedness, or sweating. And that may be the first sign that something's not going correctly. Depending on what parts of your nervous system are affected, problems after SCI can follow different patterns. But any spinal cord disorder can interfere with daily life. In general, if you can find the trigger for some of these symptoms and reverse it, that might be all you really need to make the symptoms go away. So the most important thing that somebody with an SCI needs to do to stay healthy is to recognize when your body might be trying to tell you something. Keep this in mind. Most people with SCI still have some intact reflex pathways to work with. Even if the reflex arcs are damaged, the enteric nervous system is there as a backup. Processes may be slower, but they still work. Some of the signals your body sends might end up in unexpected places and don't seem to be related. Your body map has changed, but over time, you become familiar with your new normal. The key is learning to interpret the signals that your body is trying to send you. The signals can be confusing and overwhelming, especially if your injury is new, but over time, you will recognize some important patterns. Early AD symptoms can be very mild and maybe not even recognized as AD. So even if you don't get a full-on pounding headache or sky-high blood pressure, remember that there's always a reason for these symptoms, so don't ignore them. The trouble is that no matter what's going on, the symptoms will be similar. So it's hard to connect the cause just by looking at where they're located. So if you feel like something's not quite right, you can go through a checklist known as NIBBLES, which stands for neurologic, skin, integument, bladder, bowels, lungs, extremities, spasticity, and sex organs. Sorry. This is an easy way to remember some of the noxious stimuli, which are things that cause pain usually, that can trigger increased spasticity, neuropathic pain, or symptoms of AD. So if you have symptoms like a headache, nasal congestion, sweating, flushing, or high or low blood pressure swings, go through each system in your mind and check for things like a kinked catheter, poor bowel care results, a blister, a skin breakdown, an ingrown toenail, your period, anything that would otherwise hurt. Most of the time, the problem is in either the GI or the GU system, and that triggers a short circuit in the spinal cord. Exactly how all this happens is a separate talk. Keeping your digestive system running makes a huge difference in people's quality of life. 62% of people with SCI reported quality of life issues with their bowels versus 8% of controls. But what that looks like depends on where in your body the spinal cord, or where in the spinal cord your injury occurred. There are two main neurogenic bowel patterns: the hyperreflexic or upper motor neuron pattern, which increases the tone in the colon walls and the rectum, and the sphincter gets tight, and that encourages stool retention, but reflex activity is still intact, so you can use rectal stimulation to kind of break into that pattern. The second pattern is the areflexic lower motor neuron pattern, where you lose centrally mediated stool propulsion. So things slow down. Also, the internal sphincter in the rectum doesn't close fully, so the risk of incontinence increases. Usually that needs manual disinfection. Either way, establishing consistent routines can make a huge difference. The secrets of bowel care revolve around establishing specific routines that work for your body and your circumstances. So you want to try to schedule bowel movements at predictable times, balance fluid and fiber intake to help the stool flow easily. You might need to increase your fluid intake, especially in hot weather, during vigorous exercise, or if you're fighting an infection. So how do you do that? Mostly, you want to consider your pre-injury patterns and mimic them as closely as you can. For example, morning versus evening, every day versus every other day. Take advantage of persistent reflexes, and again, most people with SCI have an upper motor neuron pattern. You can harness existing reflexes. The gastrocolic reflex is one that tells your colon when you're eating, so you can empty to make room for food that's going to be coming down the pike. So emptying shortly after meals is helpful. The rectocolic reflex is when the rectum is distended and the internal sphincter relaxes, so whatever is in the anal vault or the rectum just can come out. That way, suppositories and or digital stimulation can help kickstart the process. Craig Hospital lists some bowel program basics, and the programs revolve around diet, activity, timing, medications, positioning, and equipment. Your goal is to get the stool into the right consistency, soft and formed, not too hard, but not too liquid. And to get there, you balance fluid and fiber to soak up the water, and enough fluid to keep the movement soft and easy to pass. If you don't take enough water, the fiber gets very hard and sticky and can form a plug. Fecal impactions are really common in SCI and look just like diarrhea, but treating an impaction like diarrhea and adding medicines that slow down transit just makes things worse, because the only thing that can get past the plug is liquid. Craig recommends 20 to 25 grams of fiber a day and 2 to 3 liters of water a day, about half to 3/4 of a gallon, unless you have to restrict your fluid intake for other reasons, like heart or kidney difficulties. Thirst isn't a reliable indicator, so it's good to pace yourself through the day and watch the color of your urine. Your goal is about 125 cc's an hour while you're awake, roughly half a cup, and pale yellow urine. Activity is also a big factor, and everything counts. Sports and recreational activities are pretty clear, but activities of daily living count as well, including transfers, wheelchair propulsion at home, work, or school, and just being up and around. Note that if you need to slow down your activity level or stay in bed because of a health problem like infections or pressure sores, your bowel program may need to be adjusted, especially if the change is going to last more than a couple of days. Timing. You're going to get your best results if you empty your bowels on a regular schedule. Doing the program after the morning or the evening meal works well for most people, especially if they can harness their reflexes. Even if reflexes aren't working, keeping to a schedule with about a 2-hour window helps your body establish a regular rhythm. And you want to allow for about 60 to 90 minutes from start to finish to allow for setup and cleanup. And remember, if you plan to travel, especially to a different time zone, you'll need to plan ahead. Medications are, affect bowels in different ways. Pain medicines, especially opiates, can slow down transit and cause constipation. Antibiotics affect the bacterial balance and might cause diarrhea. Adding yogurt or probiotics might help prevent this. Knowing the names, the doses, the timing, and the reasons for the medicines you take will help you judge what effect they'll have on you. Commonly used bowel meds include things like stool softeners, bulk-forming agents, mini enemas, and suppositories. There are some medications to encourage muscle contraction in the GI tract called prokinetic agents, and these can help people with severe motility issues, but they have to be used carefully because they have some cardiac risks. Even for people with absent reflexes, it's best to reserve stimulant laxatives like milk of magnesia, magnesium citrate, and lactulose for cleanouts when necessary, rather than using them routinely. Positioning can be a big help. Let gravity assist you by sitting up on a commode or toilet if possible, and you want to make sure that the seat is padded and watch your skin. If you can't sit up, lying on your left side will also allow gravity to help. There's some evidence that manual colonic massage can encourage stool flow. There's also some limited research on functional electrical stimulation techniques, but it's not clear that it stood the test of time. No matter what bowel techniques you're using, you're going to need equipment like a shower commode chair or bench with a seat cushion, a dill stick, suppository inserter, or a glove finger, flexible mirror, non-sterile gloves, soap and water, a soft washcloth, toilet paper, underpads, and a waste disposal bag if you're doing it in bed, and lubricants, either with or without a local anesthetic. If you have sensation or experience autonomic dysreflexia, having a local anesthetic in your lubricant is a big, big help. If you have access to a bidet, it can be very helpful. The water will just help keep things clean. And again, with spinal cord injury, whether digital stimulation is enough or if you're going to need manual disinfection depends on the level of injury. And with an upper motor neuron injury, the reflexes are intact, so digital stimulation is usually enough. And with lower motor neuron injuries, the reflexes don't work, so they can't be harnessed. And most likely, you're going to have to disinfect manually. Shepherd Center has some excellent information on steps for digital stimulation. The first thing is to gather supplies so that they're easy to reach. Prepare your equipment, wash your hands, get into position, and gently insert a gloved finger and move it slowly in a circular motion until the stool comes down, and for about 5 minutes afterwards, after it stops. You can move your finger to the side or take it out temporarily so that the stool can pass. If you don't feel any stool coming down, it may be stuck higher up, so don't stim for more than 20 minutes at a time. If you can feel it, you may need to remove the stool with your finger if it won't pass on its own. And cleanup is obvious. You wipe your buttocks and rectal area, wash with soap and water, dry carefully, and dispose of waste. Clean your equipment and wash your hands. Watch for signs of autonomic dysreflexia. If they're present, stop stimming and sit up. You can insert a local anesthetic ointment. If the symptoms persist, you'll have to go to your autonomic dysreflexia treatment protocol, either nitropaste or whatever your doctor or nurse practitioner has prescribed for you. Manual disinfection. Steps 1 through 4 are the same. You're going to use gloves on both hands. Lubricate your finger. Insert it into the rectum to check for stool, and use a scooping motion to remove anything present, and repeat the process until no stool remains, changing gloves or re-lubricating your finger as needed. And when nothing else comes out, clean the buttocks and rectal area like we described above, clean up and wash your hands. If a PCA is going to be doing this, you have to explain this to them in your training, and don't hesitate to give them feedback if you need to. Nails need to be trimmed to about 1/4 inch or less. Make sure that there's gloves and a lubricant. And if you use lidocaine jelly, it has to be specially formulated for mucous membranes. You can't just use the stuff that you would put on your skin. If there's someone wearing artificial nails or polished, you have to make sure that there's no cracks or chips, because otherwise you can scratch the inside lining of the rectum. If all else fails, surgical options are available, including colostomy. And it's emotionally challenging to think about, but most people who have it don't look back, and they're very happy they've had it. I highly recommend Craig Hospital's Bowel Management video. This is the link, and don't worry if you haven't got time to write it down, you'll be getting the slides and the notes after all of this. So other than the credits, that's all there is from my end, and thank you very much.
Thank you, Susan. That was great. We're going to move on. Susan, if you don't mind just stopping your screen share, we'll move right over to Megan and Olivia.
Trying to figure it out, sorry.
That's okay.
I don't know what I did wrong. Oh, wait a minute, here we go. Stop share.
Perfect.
Thank you.
Thanks. Okay. And I'm going to go ahead and spotlight. And again, just quickly, if you do not think that we have your email address and you would like to receive the these slides, this presentation, please be sure to put it in the chat to me. Thank you. And I'm looking for. All right, there we go.
Okay. Hi guys. All right, so we are going to now talk a little bit more about food. And just like Sue said, everybody poops, but everybody also eats. So we're going to dive right into the diet aspect that Sue mentioned. So my name's Olivia. I'm one of the dietitians at Spaulding Rehab Hospital. I do outpatient as well as some inpatient coverage as well. And my name is Megan, and I cover the spinal cord injury unit as the inpatient clinical dietitian at Spaulding. There you go. So to begin, and like the primary aspect of our talk today is a lot of fiber. So you've probably heard, before that you should eat plenty of fiber, but there are certain types of fiber that you want to eat to help with whatever symptoms you are experiencing. So if you are having primarily more diarrhea, loose stools, you want to focus more on soluble fiber. And if you're having more constipation, tougher stools is where you'll want to focus more on insoluble fiber. A lot of foods have a mix of both soluble and insoluble, but there are some that we've highlighted here that have a little bit more of whichever type of fiber you're looking for. All right.
So the way that soluble fiber works is almost like a sponge. One of the best examples of a food that's high in soluble fiber is oatmeal. So if you think about the way that when you prepare oatmeal, cooks in water or milk, absorbs that liquid, does that same thing in your digestive tract. So it absorbs some of those liquids throughout your system to kind of help slow things down. It also helps to kind of stop some of that loose stools. For some people can also keep them full for longer, can help with blood sugar control. It also has a good benefit of removing some of that bad cholesterol, because in that fluid, as it's going through your system, sometimes there's some cholesterol floating around in there, helps you poop that right out.
That's why we love oatmeal around here. But
Yeah.
some other examples of high soluble fiber foods are bananas. So when you think about like the brat diet, if you're having a lot of loose stool, not feeling great, bananas, great option. Oat bran, barley, nuts, seeds, beans, applesauce, also part of the brat diet, and potatoes. But so typically when we're recommending more soluble fiber, to stick to bananas and oats, because those tend to be the highest in soluble fiber and have the most impact.
A lot of people, if they are experiencing more issues with constipation, those are two foods to also kind of look out for, because maybe those foods you kind of need to play around with to find a good balance of doing those in the frequency.
You may need to cut back a little bit.
Yeah.
On the other hand, there's the insoluble fiber, which we like to call roughage. So this is what's going to add bulk to your stool to help push things through. Sue talked a lot about peristalsis, and we're trying to just move things along in the digestive system. So insoluble fiber is going to push things along, but also promote more rapid passage through your digestive system.
Got a little mush and a little push. Some of the insoluble fiber foods are a lot of times some uncooked vegetables and fruits with skins, especially beans and legumes, nuts, whole grains, brown rice. A lot of the foods that we typically think of as being very high fiber foods.
And you'll notice on our list here that like some of the foods that we mentioned are under both soluble and insoluble, primarily like beans in that sense. And that's, like I said, a lot of foods have a mix of both. And we also like to emphasize that everybody has a different response to these foods. It's kind of like with cheese. Some people find cheese causes a little bit of loose stools. Other people find cheese causes more constipation. So really paying attention to your body, what you're eating and what you're experiencing, so that you can make some tweaks on your own.
Also, we can't do our presentation today without talking about my favorite food, which is prunes.
The superfood of them all.
It's the best food. Prunes have about an equal amount of soluble and insoluble fiber. It's just like this perfect combination. It also contains natural form of sorbitol, which is a natural laxative. So that's why they are such a magical fruit. Doing just a couple of prunes a day sometimes can help to kind of push things through the system. And they do have a total of like 3 grams of fiber per serving. So it is quite a lot. So that's why, start slow.
Yes.
So you can see a response.
And being consistent with it. I feel like consistency is key. Some of the nurses that I work with on the spinal cord unit at Spaulding will swear by warm prune juice. Something about it being warm just kind of pushes things along a little bit better than if it were cold, but something to think about.
And the general recommendation is between, it goes anywhere between 20 to 30 grams per day. Really, the biggest thing is if you're having any of these symptoms, if you're having issues, kind of seeing if you can add more fiber, where you need to kind of make adjustments and kind of space things out a little bit better.
So just to kind of give you a little high fiber versus low fiber foods, because this is, we talked about soluble versus insoluble, but in general, if you're trying to increase your fiber intake overall, trying to focus on more whole grains, fruits, and vegetables. And if you can get the skin in the vegetable and the fruit, that's better too, because that's going to give you more of what we call the roughage.
And then there are, of course, foods that don't have very much fiber at all. That's going to be our meats, our eggs, our cheese, a lot of the white grains that we have, because the white grain, has all that fiber stripped out of it. Dairy products, fruit juices, unless they have like actual pulp in there, usually they don't have any of the fiber in there. And applesauce is actually a very low fiber food. As we were talking about before, a common like sick day regimen is that brat diet, that banana, rice, applesauce, toast. Those are foods that are low fiber and that are easy to tolerate. on those days where maybe just things are not going so hot, and you kind of need a reset.
So we couldn't not talk about protein and constipation because, part of our job is often promoting more protein intake for, maintaining your muscles, your strength, and, it's just all in all an important aspect of your diet. But there are some protein-rich foods that can contribute to constipation. Particularly, we talked about cheese for some people, beans, milk, poultry, meat, a lot of the protein-rich foods can contribute to constipation, and that's why it's important to pay attention to what works best for your body and your diet and your lifestyle.
I also think that sometimes, people will tell us that, I feel like, cheese or meat or something like that is really causing constipation, but maybe it's because, that meal also didn't have very many of the high fiber foods in it. It was more of like a meat and potatoes type of meal. It didn't really have too many vegetables in it. So it's kind of hard to say whether or not it's the meat itself, or really just that it doesn't have very much fiber in it. And that's maybe the bigger part of the meal. Got to think about the whole, not just the sum of the parts.
Right. And also hydration.
Yeah.
I think that's our next slide.
Yeah, I think it is.
Good segue.
Oh,
it's
no.
not. Oh, well. So we did put in a slide here just to talk about an ostomy. Some people do take the surgical route after having a spinal cord injury or for any other reason to have an ostomy. And there are some foods that are high in fiber that can cause some issues with an ostomy. So some things to pay attention to are definitely if you're eating something and you're noticing a lot of gas afterwards. And that can really come from what we call like high FODMAP foods, where they have a type of fiber in them which is not easily digested by your body. That's mostly going to be like your apples, broccoli, cauliflower, any cruciferous vegetable, Brussels sprouts, cabbage, but also your dairy products and high fat foods. That will tend to cause a lot of gas, a lot of odor, that sort of thing. So if you notice that, some things to look out for.
And while we are kind of highlighting folks with ostomy, everybody eats, so also everybody passes gas as well. So you may notice that some of these foods do cause an increase in issues for you as well. There are some foods that we do want to be really more cautious of because they may cause more of a blockage. Celery, those little strings on there. Corn is a great way to examine how long your digestive system takes, because it looks about the same when it goes in as it does when it comes out.
Yeah, just try eating corn one day, wait a few days.
You'll see how fast
Keep an eye out.
your digestive system works. Nuts and seeds, sometimes just those little bits can get really stuck in there. Pineapple is very fibrous, some of the fibrous tough meats. And then sometimes just the particular skins on different fruits and vegetables. Not all these cause issues for everyone. I've heard most commonly a surgeon will recommend for somebody to really avoid corn niblets, because that's really the biggest trigger.
Or chew your food really well.
Yeah, really, really well.
And drink adequate fluid.
Yeah.
All comes back to that.
And with an ostomy and also without an ostomy, it's really important to kind of start slow. If you don't really have that much fiber in your diet, start it slow and increase how much fiber you're taking kind of slowly, and then just kind of monitor your symptoms, see what's going on.
Here we go with the fluid. So Sue had mentioned as well, really paying attention to how much you're drinking and staying ahead of your thirst. I really liked that point that she had mentioned. Olivia and I were kind of chatting at that point where it's when you start to feel thirsty, you're kind of behind your hydration. And you really want to keep your urine color a really, really light yellow. You don't want it to be totally clear, but really, really pale. So we have these two examples here of well hydrated versus dehydrated. And oftentimes in the morning you'll be more dehydrated, which is to be expected because you've gone maybe 10 hours without drinking fluid, but throughout the day really paying attention to your urine color.
We want it to be you want to say it? You want it to be
It wasn't my saying. Someone once said you want your pee to be the color of champagne. So I once had a patient say, what about Sauvignon Blanc? Whatever floats your boat.
Miss Sauvignon Blanc. There's really no magic amount that we can kind of prescribe to people. It's really more about kind of yourself and your body and really your pee. But kind of the general recommendation is that most adults need between 1 and 2 liters. A lot of people use the example of kind of calculating half of your body weight in ounces. which when I do that calculation for myself, I know it's a little bit above what I estimate my own fluid needs. So, for people who are already hydrating pretty well, that can be a good kind of goal to strive for. You don't want it to be like completely clear all the time, because you can definitely, really overhydrate yourself. And then you're just peeing all day long, and that is no fun.
Which leads into as well, like if you notice you're having incontinence overnight, or you're getting up frequently overnight because you have to urinate, trying to space out when you're hydrating so that that doesn't happen, drinking more earlier in the day as opposed to later in the day.
And really trying to focus on lower calorie fluids and fluids that don't have too much caffeine. While caffeinated fluids do count towards your hydration goal, they can kind of dehydrate you as well. So I don't want that to be your primary hydration. Trying to do like water, sparkling water, maybe water with a little juice, something like that.
Yep, trying to stay away from like, the high calorie juice from concentrate. Milk is honestly a good option. It gives you a little bit of protein. Certain juices from 100% fruit juice will give you, some vitamin C. So there's a lot of good options out there.
Yeah, especially if you don't just like regular old tap water.
All right, so we wanted to give you guys an example of what a day would look like. We recommend 20 to 30 grams of protein fiber per day. And, what does that look like if you were to try to attain this? So we have two different examples here for you.
So we were just kind of showing how you can kind of incorporate both high fiber foods and foods that are maybe a little bit, lower in fiber to kind of build a good routine, and incorporating those throughout, all of the meals and snacks that you're having throughout the day. You're thinking about that like 20 to 30 grams per day. You're going to have 3 meals per day. That means you really need to, and you're not having any snacks. It means you get like 10 grams each meal. If you're having a snack, then maybe you can make it a little bit less each meal.
But we also love to think of snacks as an opportunity to make up for anything that you're lacking in the day. And I feel like a lot of times that is fruits, vegetables, and fiber. So if you are having a snack, try to have a fruit or a vegetable with it. But you'll notice here, we love our oatmeal, wheat toast. You can definitely still have, a sandwich or some pasta, and it can still be, a high fiber meal for you.
And a lot of like some of the new products as well, you'll notice things that do have a little bit more fiber, and then there's a lot of different bread options that are whole grain that don't just taste like cardboard, that are pretty tasty and have a good amount of fiber.
Oh man, the story of your poop, how to pay attention to, what you're experiencing with any bowel movements that you are having. So we actually refer to this on a daily basis.
Yeah, we have this posted in our office. So this was scanned into the system. This is what we call like the Bristol stool chart. So a lot of gastroenterologists might have this on their wall whenever you go to see them. It kind of helps them better understand what your poop looks like, and what it's trying to tell you.
So you're aiming for 3 or 4. You really want it to be like formed, not too loose, not too hard. I don't have anything else to say about this. I think it's pretty self-explanatory.
It is pretty self-explanatory. But number 1 and number 2 do tend to indicate that maybe you're having too much fiber, not enough fluid, like you're not having a good balance, or you're having not enough fiber at all, and it's just kind of like hard and there's not a lot of like content to go through. Number 5, 6, and 7. 7's kind of, really past. Maybe you need to go see the doctor, but number 5 and 6 can mean that like maybe you need to add some of those higher soluble fiber foods, like those oatmeal and banana, that type of thing, to kind of get it a little bit more solid. Sometimes the doctors will say they want it to be a nice chocolate soft serve.
I love that. But either way, it can mean that you're either eating too little fiber, too much water, not enough water. So everybody needs to kind of pay attention to what they're eating and what their poop looks like.
Yeah.
We did want to touch a little bit on prebiotics and probiotics, especially because we're talking a lot about, if people are having loose liquid stools, like the number 7 on the Bristol stool chart, which often happens after people are on antibiotics and they're experiencing a drastic shift in what their bowel movements are looking like. And that is because antibiotics are disrupting your gut microbiota. And so you kind of need to replenish the good bacteria and get back to your like healthy balance of good and bad bacteria in your digestive system.
There's a kind of a natural amount of these bugs, these probiotics that live in our system. And sometimes, you know, after that type of instance, we need to kind of add more of those bugs. Those bugs are the probiotics, but those bugs also need food. That's the prebiotic. So prebiotic is usually in a fibrous food because those bugs like to eat the fiber that we don't really digest super well. And then probiotics are usually fermented foods because fermented foods will often have small amounts of these healthy bacteria in them.
Like sourdough.
Yeah.
You have sourdough bread, yogurt, kimchi, all that good stuff.
So, you know, there is a lot of different food options for these, but sometimes people do want to try and go towards more of like a supplement, like a probiotic supplement. The biggest thing that we always tell all of our patients is that supplements are not regulated by anybody. So you need to choose a supplement that has been regulated by a third party, by like somebody else coming in there to look at the product, make sure it is what it's supposed to be, make sure it's not what it's not supposed to be, and that it's safe. So you'll see those two little stickers there, that NSF and that USP. Those are two of the bigger companies that are third-party regulators that you might see on your products. And if you see that, then you know that okay, at least this is what it says it is, and what, you know, it's not anything that's not supposed to be.
Mm-hmm.
And this can also take some time, like rebuilding your gut microbiome.
Oh yeah.
After
It's not quick.
But depending on the antibiotics, some of them really kill everything off, and some of them, you know, maybe only kill a little bit. So
especially if you've been on antibiotics like for pretty consecutively, like some people will have, you know, multiple infections one after another, and that's when it takes, you know, a good chunk of time to get back to your normal.
Don't get discouraged, but also, you know, if it's really persisting, you can always reach out to your doctor to see if they have any recommendations.
Yes. Okay, so we wanted to put in a little plug here because we gave you the basics of, you know, what is fiber, what is soluble versus insoluble, how much fiber do you need, fluid, you know, probiotics, prebiotics. There's a lot of information here, and there's a lot of things that can affect your bowel movements. And, you know, it's definitely an ongoing topic. And so we put a plug in here for Olivia and I co-host a weekly nutrition support group. We talk about poop all the time, but we also talk about other fun topics like heart health, your favorite recipes, hyperlipidemia, mindful eating, and we just have fun conversations. So if you're interested, the link is through the Greater Boston Spinal Cord Injury Association peer groups. And so feel free to join us. It is at noon Eastern time every Tuesday.
Yeah. But if you're looking at this presentation, you're like, golly, you know, I have a lot of questions and I feel like they're really specific to me. I highly recommend seeking out an outpatient dietitian who is familiar with spinal cord injuries or disorders to provide a little bit more like specific recommendations for you. Because you might be like, okay, you know, these recommendations make sense to me, but I also have this other medical condition that, you know, I don't know how to balance those two different things. Mm-hmm. I'm not trying to plug myself, but I am.
I told her to plug it.
I'm the outpatient dietitian at Spaulding. It's all virtual right now, but it is limited to Massachusetts residents. So if you're outside Massachusetts, you know, there's plenty of other dietitians out there who can help you.
But like we said, everybody eats, everybody poops, but everybody's different. So you may just need a little bit of individualized support, and that's what we're here to help with.
All right. Thanks, guys.
Thank you.
Thank you. All right. So we're going to, that was great. We're going to move along to our panelists. And if you just give me a moment, it's just taking me a second here to figure out how to get back to my gallery view. Okay. I'm just going to, so we are going to start, we're going to hear from 5 different panelists. And as you'll see, they're all, you know, different injury levels, very different experiences and different ways that they manage their bowel health. And we are going to start with Donna King. Donna.
Hello, happy to be here. So I am a paraplegic for about 45 years, very low injury, T11, 12. And I have great success with my bowel health. And I think what it all comes down to is what I put in the timing of what I put into my system. So huge amounts of fiber and water. I think constipation is always based on lack of fiber and your digestive system being dehydrated. In addition to what I eat, I'm also obviously mindful of things that are nutrient dense and not too much calorie dense. So I think that if I eat often during the day, so that I don't have a long stretch of time where my digestive system doesn't have anything to do. So during the day, I'll be nibbling some vegetable sticks and some hummus or something else that is not calorie dense, but is high in protein, because I feel like I don't want my digestive system to be doing nothing for 5 or 6 hours. And then I think it gets stagnant. And I think if I'm constantly just eating little stuff, pushing it through, and also I typically avoid processed carbs. I avoid high greasy fat food. I find that once my digestive system, if it gets dehydrated, then it takes a couple days to get it back on track. So I do my bowel care every other morning, right after I have my oatmeal and my berries and all that. Sometimes a nice cup of warm herbal tea before I go in. It's clockwork. It's very smooth. Very infrequently, if I do not have a very successful movement, I don't wait 2 days, because then it would almost be 4 days. So then I would maybe do some Marilex and then do the following day and then get back onto every other day. I also avoid white stuff like white bread, white potatoes, because I just think that my body doesn't have any use for them. And it's not going to help move everything. I know I don't have the right medical terms, but it's not going to help move everything along the digestive system. Another thing I find, if people are able to do so, that's very helpful, is stretching, because I find if my hip flexors are tight, it can make your rectum tight and it can make it more difficult. I have the ability to stretch. If people have the ability to stretch, or have somebody stretch them during the day or at night, if you can lay at a 180, because so often we're at a 90, and I just think that it gives those muscles a chance to to relax, so that then when it's time to take care of what you need to take care of, things will go a little easier. So that's pretty much what I do, and I just know that it works wonderful for me.
Great. Thank you so much, Donna. That was great. Okay, we are moving to, sorry, just gonna take the spotlight off of you, Donna, and let's see. Next we have, I don't know why I can't get back to my, okay, here we go. Tony.
Hi, my name is Tony. I'm a C5 quadriplegic, 45 years post-injury. And at the beginning of my injury, I had a lot of constipation from medications that I was taking for spasticity, and found that to be a problem, and would go to the extreme of taking too much fiber laxatives and having blowouts. So then I changed my diet to mostly vegetarian. I'm not a vegetarian, but I don't eat a lot of red meat or that sort of thing, because it slows my gut down. And I find, like Donna, eating lots of fiber throughout the day and drinking a lot of water keeps my system moving along well. And it's I don't use laxatives anymore, because the high fiber diet takes care of the bowel regiment. And I avoid white food unless the stool is loose. Then I might eat a potato or some rice. I avoid sugar for a good amount of my diet, just to keep my sugar level low, but I also find it loosens my stool. So just being aware of what I take in has made a big difference. And I have successful bowel routine every other night. I do my bowel routine at night. That way, when I'm in my chair during the day, there's no accidents. If I'm going to have an accident, it would be at night and not when I'm out in public. So high fiber diet, lots of fluid, and occasional starch to tighten things up works really well for me. So great presentation by everyone, and thank you for having me.
Thank you so much for sharing, Tony. We are going to go over to Matthew right now, if I can. There we go.
Hi guys, I don't think I've ever been to a Saturday Ed series. My name is Matthew. I'm a T10 paraplegic. I have a colostomy bag. It's something I chose to go with 3 years into my injury. So I think I'm at like 5 or 6 years now, hard to remember. But I had a really difficult time, like just straight from the get-go. I was having accidents constantly. I was always constipated, no matter how much Miralax, how much fiber, how much I drank, how much I changed my diet. I was just always chronically constipated. I had a gastroenterologist who dealt specifically with neurogenic bowels, and I was on, plenty of different medications, and I never got a really good routine, and it really affected me mentally. I would have accidents. I would always have sometimes these mucus blowouts, and it really got to a point where it was just taking over my life. And I met with a surgeon, and he kind of explained the process a bit, and I had a meeting with a colostomy nurse. And I have to say, it is easily been the best thing I could have ever done for myself. It has given me such a sense of freedom. I've never had an accident. I can travel without a chair. I can travel anywhere and not have to worry about 8 o'clock on the dot. I need to make sure that I'm on the toilet. Yeah, I just, it really gave me an unbelievable sense of freedom. I think there's a lot of stigma around colostomy bags that people don't really understand them actually that well. But yeah, it's the best thing I've ever done. And I am happy to field any and all questions, here, or if you guys ever want to message me. I am very passionate about the colostomy bag, and would love to, explain it to anyone.
Thank you, Matt.
Sure
That's
thing.
great. Thank you so much. Yeah, and we'll definitely be taking questions shortly. So next up, we have Brett.
Hi, my name is Brett Swanland. I'm a C8 incomplete quadriplegic. I've only been injured a little over a year and a half, so by no means am I any expert on any of this. But what I found works for me is because I kind of lack the finger dexterity, I use tools to put my suppository in. I use a magic bullet, which I started using at Spaulding. So I use a tool for that. I also have another tool for digital stimulation. And I normally take one of these probiotics a day. I think it's 20 billion. And I do take a stool softener in the evenings and one in the morning. So I take 2 of those a day. I kind of, before I was injured, I probably didn't have the best gut health. I was probably going 2 to 3 times a day, and usually it was loose, possibly explosive. So it's kind of refreshing to only have to go once a day, but it does take about a half hour to an hour. So but I do go every day. So that's been working for me. I would say overall, I probably eat less, but I think I eat a lot more health consciously now than I did before. And honestly, I think while I was at Spaulding, that was probably the healthiest I had eaten in years. So I tried to carry that over into my home life. I started doing Hello Fresh meals, which generally are pretty healthy. So yeah, that's what I do. I have a roll-in shower chair, and after I'm on there for half hour to an hour, everything's pretty good. I do sometimes have accidents, but they're pretty infrequent, and usually it's like a mucus discharge. It's not like a full blowout. I do have sensation below my injury, so I get like a little feeling like something could happen, and if I'm lucky, I have somewhere between 30 and 90 seconds to get myself in a position where it's not going to cause a huge mess. And when they do happen, it's generally at night, and about 90% of my accidents have been at home. So knock on wood for that. Yeah, and if anyone has questions, like I said, I'm no expert, but I can share what works with me. And thanks to all the presenters, great stuff.
Thank you so much, Brett. And lastly, we have Maria.
All right, I guess everybody said everything, so I don't need to talk a lot.
No.
That is great. Thank you, everyone. It's very good a presentation. I have a car accident in 1996, so I'm quadriplegic C4, C5 complete. What I do, I have my bowel care in like a program, and I do go to the bathroom every other day. So I eat a lot of fiber, I drink a lot of water, I do exercise 7 days a week, the movement, and I do the massage on my belly also. I try to eat vegetable every day, fruit every day. I try not to eat what I'm not supposed. When people offer me, I see my kids eat, I say, you know what, I'll be right back. I just move out of the way. That way I don't feel like, oh, okay, the water is coming to my mouth, I want to eat. So I try to do my best. And the time I'm going to the bathroom, I always lay down on my side. I do every day, I do on the bed. I try, if I go take a shower in the bathroom, I'm gonna go to the bathroom. So I don't take a shower every day, I take it every other day. So that's why I do. I lay down on the left and I move my bowel, I go to the bathroom. The rest is inside. When I go take a shower, always it come out. So I think I've been doing that for more than 20 years for now. Because once I was in Spaulding, when I coming home earlier, I wasn't able to do very well. But now I'm very, step by step, I'm follow up, like grow like a grown-up woman. So I try to do my best. And for me, the bowel movement is like exactly what I eat. Whatever I eat, that's why I work it out. So whatever I drink, that's why I work it out. If I have any problem, or I didn't follow the rules, I break the rules. So I try to follow my rules. So anybody have any question, we're here to answer. And the bowel movement is like you eat. It's like you education for what you drink. Because if you drink something wrong, you go on the wrong path. So if you eat wrong, it's the same thing. That's why I follow. So everybody say everything. I don't want to repeat whatever they say. So thank you so much.
Thank you, Maria. Great. All right. So we Thank you so much to everybody. We're going to move to questions. I'm checking the chat. But if you also, if you want to put a question in the chat, if you want to raise your hand, we could try to get to you that way. So I do believe I saw Emmett's hand up.
Hey, Heidi. Yeah.
Hey.
Thanks, everybody. This is really informative, a subject that's near and dear to my heart. I have a question for Megan and Olivia. Before I do that, though, I wanted to mention, like Matthew, I have a colostomy. I'm a C6 without any hand function. So if anybody has concerns that are unique about colostomies and like how do you manage it if you don't have hand function, I'm happy to talk with people about that. I do it independently, so it can be done if you're interested in going that path. But for Megan and Olivia, my question is a little bit unique. I have a problem with heterotopic ossification in my hip, and it's creating I have a big bone mass in my hip that is kind of pushing up against my organs. And one thing we found that it's doing is it's partially obstructing my colon. And as a result, I have a massive problem with kind of chronic constipation. And I've tried to manage it using all the smart things you do, right? Like I eat tons of fiber. But there's always a question burning in the back of my mind that if it's partially obstructed already, is adding bulk really solving my problem, or is it possibly causing more problems? And I haven't heard a good answer from anyone. I wonder if you guys could help me think that through.
That's a great question. It's more bulk, like you said, is going to cause more, more of an issue there if there's not as much space to move it along. So I feel like, there is a point where too much of one thing is not always a good thing. So, it may actually help you to kind of cut back on your fiber intake and see actually if the change in the type of your stool and, maybe even paying attention to the Bristol stool chart and seeing, how it's coming out. Is it really formed? Because the more formed it is, the more it needs to kind of get by that mass like you're talking about.
I would totally agree, especially because like we were saying, fiber, we love fiber so much, we can't hype it enough, but fiber is not, the whole point is that it's not super well digested by our body, so it has to be excreted, which can be beneficial or detrimental. So that's kind of like adding more content to the whole situation. I also think that delicate balance with the water is also really, really key, because if you're eating a ton of fiber, you also need to be drinking a ton of six water. You also need to be drinking a ton of water as well, which can be really challenging. So sometimes I found this helpful for myself. I had to do it for a school assignment, keep track of my intake, and I figured I was eating quite a lot of fiber. Sometimes even just inputting it in like a food diary, just so they can kind of calculate how much fiber you're actually getting. You're getting like, 50 grams or something like that. You're well exceeding the recommendations, and it might be better to kind of like stick to those guidelines because they are there for a reason. So see if decreasing it might help.
I say try decreasing it, drink plenty of water, start there. It always helps to start with a starting goal.
Helpful, thank you. I can tell you your target, like 20 to 25 or 25 to 30, whatever it was. I've heard numbers much higher than that. So I've been targeting like 38. And as you said, like I've been up over 50 plenty of times. So, maybe I'm a little heavy handed with this. Good, thanks.
Yeah.
It's really easy to overdo it.
No, it's not. It's so hard to eat enough fiber, it turns out. I have to put a lot of work
No,
in
I mean,
if I want to get 50 grams.
50 grams, I can't even get up to. I mean, I would definitely agree that maybe increasing your water intake if you can, balance.
If anybody wants to hit 50 grams of fiber, there's a product that Whole Foods has. It's a frozen vegetable side dish that California blend or something like that. It's got like 50 grams in it, so you can knock out 2 days worth right there if you want.
Thanks for the tip, Emmett. That's great. Thank you. There's also a wrap that I use made by Mission. It's a carb balance one, and it has about 20 or 25 grams of fiber in it also. Keith,
I had a question for Dr. Bergman. I was prescribed lactulose twice a day when I was in Encompass Health, and I stopped taking it in the morning because it was causing accidents. But I started taking it twice at night instead of once in the morning and once at night. And I noticed on one of the slides it said you shouldn't really take that every day. So I was just wondering, am I doing something wrong now?
I would definitely talk to the prescribers. I'm not sure. I don't know if there's another issue that seems like a lot. I mean, what we used to say is when somebody had an impaction where they were partially plugged and the only thing that got by was the liquid, we used to put people on lactulose. And I think we used to say, I think it was 10 cc's every 4 hours until everything came out. So I'm not sure why they would have you on lactulose twice a day. And like I say, not knowing your specifics, I would go back to the people that, recommended it and maybe take another look at your diet and see if there's some, something you can do there and maybe cut back on the lactulose over time.
Okay. Does it cause problems, the lactulose, in any way, or?
Well, the main problem is that your body gets used to it. And, if you become dependent on it and then you fall out of balance, say it's 100 degrees for, 2 or 3 days in a row and you fall behind on your fluids, it's going to be tough to get things going again. That's the main trouble with it.
Right. Because right now my body's so used to taking it twice a day. I've been doing it for over 2 years, and I can't really go back and talk to the doctors there because they're not even going to remember me. That was a long time ago. So I can't really go back to them.
Do you have a physiatrist that you see, or?
Yes.
Talk to them, see if they have any words of wisdom.
Okay.
And hopefully that will help. And if not, you can, talk to us again.
Okay. I mean, I do have a physiatrist with Spaulding. I probably should make another appointment with her and follow up. So thank you.
Thank you.
Thanks. I'm going to go to Jenna Marie, and then we have a couple of questions in the chat. You're muted. You're
in
muted.
my background.
Oh, good. Okay.
Got a bunch of kids here. Is that a game? No. Quiet, please. My question is, so I'm my husband's caretaker. I'm Jenna. It's so nice to meet all of you. What he tends to do every morning is to take a protein shake with some super green powder, and then he has coffee. And I know coffee is a natural laxative, but a lot of his stool is often in the 5-6 category, and rarely it is in the 4. And since he had his surgery, my husband has neurofibromatosis type 2, which are tumors that grow in the spine and the brain. He has had a distaste for vegetables. And we all know vegetables are good for you. So, we try to sneak that in with the superfood greens in the smoothie. But I'm wondering if the coffee is a problem, if that's because we're trying to get him, he used to go every morning, and then that would be done for the day. But now he's like constantly unsure if he needs to go all throughout the day. And we all know that when you can't regulate your bowels, then you can't really go anywhere. You just stay home all day. And that can be frustrating. I'm going to mute because we're loud here.
I think I would look at if there's anything higher up, that if this has been going on for a long time, he could have a partial impaction, and then it kind of looks like you've got diarrhea, but really what's happening is that you've got a partial plug, and the only thing that can get by is the liquid. So if this has been going on a while, when you put a finger in, do you feel anything at the top of your finger?
I haven't tried that at all. So this is new information for me. I've never tried doing that. We've never done the plug either.
I mean, maybe
had
the suppository.
occasionally- Sorry, it's so noisy
Sorry.
here.
Oh, don't worry. I get it.
It's okay.
You know, putting in a suppository might help, because I have a feeling that what you're seeing is that he's got stuff up higher that hasn't had room to come down quite yet.
Yeah, great question. Thank you. Thank you. Abby says she's intrigued by Donna's practice of eating often to keep the system stimulated rather than having longer pauses between bigger meals.
So is that a question? You want me to elaborate a little bit more on it?
You can, or would Susan, Olivia, or Megan comment on why that's a good practice?
I gotcha. Okay.
And whoever wants to.
I think it makes sense, and all I can, it's hard to say. It's all a balance, and just like we can't all wear the same clothes and we can't wear the same shoes, we can't all do exactly the same thing. So I think I like Donna's thoughts about kind of shifting things a little bit, finding a balance. I think in general, if you kind of wait in between, you take like 2 meals a day, for example. By the time you have that second meal, you want to eat everything in sight because you're so hungry. And, so I think that pacing yourself in general is probably better overall. But, you have a life to live too, and you have to kind of find a balance that works for you.
I think also it's, we mentioned like the snacks and how the snacks in between meals are an opportunity to kind of make up for anything that you're missing at meal times. And, we said a lot of times that is like your fruits or your vegetables. So that's when you can kind of make up for, any lower fiber intake at meal times. But also kind of stimulating the peristalsis, which, is what's going to help move things along ultimately. And that's triggered by when you are eating. Yeah, that was good. Thank you.
Yeah, it's great. And Pam is asking, is Senna every day a bad thing to take?
I don't think so. It's certainly what was recommended, early on in spinal cord injury care. Senna is basically fiber. There is I think it has some sorbitol in it. But I don't think it's a bad thing. If you're not having trouble with it, then I wouldn't be too concerned about it. If you are having trouble, I would go back to your prescriber and see if you need to recalibrate. But I think there are a lot of folks who were injured a while back who are, I prescribed Senna myself for eons. So
I also think that to Sue's point, I get a lot of questions about, different diet things, and like sometimes there's really a limit to the food. And I always recommend people go back to your physiatrist. They're the ones who know the neurogenic bowel the best. There are like a few SCI specific gastroenterologists out there, especially in the Boston area. They're kind of harder to get into. But your physiatrist, they know you, they know your body, they know your injury level, and so they can better tailor that medication regimen for you and kind of answer your questions about like, is this the best thing for me? Should I be adjusting it?
And as well, like, over time, your body, changes. And so your regimen may need to change too. It's not always going to be the same thing.
Cannot recommend physiatrist, no.
Thanks. Steve Austin. Steve, I see you have your hand up.
Oh, you're
Okay, yeah, I
muted.
was muted, sorry. I have a question about probiotics. And presumably, the body has all kinds of organisms in the gut. And yet, when we go to CVS and buy some probiotics, we seem to get one species. What do you need to take for probiotics to get a balanced set of organisms that are beneficial? Is one okay, one type okay? Should you have a variety of different kinds of probiotics to get a mixture? This has never been explained to me, and I'm really scratching my head over it.
Do you guys want to take it, or do you want me to take it?
Sure, we're happy to.
Yeah. We were just saying that, yes, in the supermarket, there's usually like the lactobacillus is kind of the most common one that they'll, do as a supplement pill, or sometimes they'll like add it into a food. But we were, kind of the food aspect of the probiotics, those fermented foods have more of like that natural balance of the different bugs that we want. So doing a little bit more of those. I know there's sometimes like weirder foods that people may not eat more of. We had a good talk a while ago about kind of incorporating those into your, your routine more. But like yogurt and like kefir, those are, kefir's a little bit weirder. But yogurt's
a great option.
Yogurt's a great option. Yogurt every day. Sauerkraut, those types of things that are kind of like natural fermented foods.
I think it's important to highlight here that, there are probiotics on the shelves out there as a supplement, but your body digests food and supplements differently. So it's really helpful to try food first. That's one of our biggest sayings, food first, and go from there. So I think in this case, if you're looking for a variety, go for food. Yeah.
Okay, good answer. Thank you.
Thank you. Yeah, food first. That's a good one to remember. Food first before supplements. Nicole.
Hi.
Hi.
Hello. So I was hoping to get some advice on for my son, who is a C4 complete injury. We do program. I'm going to turn up the video. I didn't expect that. Sorry. We do program every other morning. We have a girl that comes in to help with shower. So the situation is that he goes to the activity-based therapy every morning and has been having, it's just a constant, he has accidents. So we do program in the morning though, because he's up, he's with his friends at night. We're trying to, kind of keep the, mentally, it's helpful to be with his friends at night and to do the program in the morning, but then we go off to physical therapy. And most of the time he has accidents there, which is, embarrassing. And we roll with the punches and he gets back and finishes. So I was just hoping to find maybe, advice. I know the situation is unique in that after program, an hour later, he's going to physical therapy. Once in a while, he does not have an accident. I didn't know if anyone had any advice on trying to prevent involves or accidents.
Well,
I guess
timing.
Program time, but I don't know if we can fit that in nights.
Well, I wonder what time do you do physical therapy? Could that be maybe an hour or two later?
We could try that. I think more realistically, we'd have to do program pretty early in the morning. I guess I maybe already know what may need to be done to prevent. But we've tried so many different things about going back up, trying to do program a bit earlier, starting it at 5 a.m., letting them, after program, waiting another 20 minutes to 30 minutes to go back in to see if there's more. Sometimes there is, sometimes there isn't. We just can't figure out the rhyme or reason to that much. But I don't think it's the diet with having those involves. I don't know that I can make the timing because it's, like waiting list, et cetera. We got this prime spot. He does 3 hours a morning. I don't know, other than, go ahead, sorry. A
couple of the panelists talked about doing program in the evening so that because often, there is a lag, and you do the stim, and maybe half an hour later, something will come down. So if there's any way to do it at night, even if it's a little bit late, maybe have an apple or something and then do program. I don't know how late he's out it with his friends, but, it might, if he's back by 10,
Right. Yeah.
it could be all done by 11:30 and, get a decent, that way kind of everything can be balanced.
Okay. So you probably agree that it's just the schedule, and
Yeah. I think
there's
so.
really nothing that we're doing wrong or could be doing better in a way. It's really just the fact of the matter is he's doing program in the morning. A couple hours later, he's doing this intense physical therapy, which is going to get things moving up there. Either way. Yeah.
Yeah, and I see Caitlin had something in the chat. I agree. Switching to night and maybe trying every other night might be a lot less stressful.
I don't know if I could. I'm sorry.
No, go ahead.
I was just going to say, I really understand this situation, because it's so hard, because you do really want to keep that level of like normalcy when we're living people with a spinal cord injury, we're living in a such like unnormal state of existence now, and that's a really fine line. So I really understand that mental importance. What I wanted to say, and what it sounds like, and I think Donna said this, but my first question is, does he use a suppository?
No, doesn't need one. The program goes really well.
Really? Okay. I used to find quite a bit, like when I used a suppository, I was guaranteed later to have an accident, or I was guaranteed that like it was such a delay for me that, like, because if you think about it, you have like, my routines took hours, but you're sitting there for like 45 minutes to an hour, and there's so much concentrated stimulation to that area. And because I think the nerves are so much slower where that information is going, I think what's probably happening is, one, he's getting a lot of stimulation, then he's going to physical therapy, which is even more stimulation. So, it's a challenge, but I used to have my bowel routine in the morning, and I noticed quite a bit, like when I was in therapy, I would have accidents. And then I did switch it to night, which was difficult because I felt like me mentally, I was anxious. I was going to have something happen, or my stomach was going to be in pain. But I did notice that when I did switch to night, I had less accidents.
The next day at physical therapy?
Yeah.
Or just in general? Because he doesn't seem to have them any other time. When he first got home, he's about a year injured. When he first came home, he had a few, but since then, the only time he has an vol is there.
Then it sounds like what's happening is all of that physical therapy, which is fantastic. He's moving a lot. He's putting pressure on his abdomen, right? Because he's transferring, he's moving around. That's what's probably creating it. So I think maybe that's your answer right there. That's like the key factor that's going on.
Changing the time,
but maybe just considering how you go about it on the days of physical therapy.
Okay. I just wish you could get it all out and know for sure it's all out.
Yeah.
There's no way to do that.
Well, I wonder if he's not using a suppository, if he started like half an hour earlier, just maybe not on a day when he's got PT, but try a suppository and see, especially a magic bullet, which tends to work pretty quickly.
Or half a suppository.
Or half a suppository, right.
Okay, and then you wait, right? And then you go up when you do the suppository, or does it just come out on its own?
Either way.
I'll wait and see. I'll see. Okay.
Yeah.
I would refer, like, Susan, you would probably know better, but like the suppository is supposed to melt inside, and then what it does is it stimulates. So your body's temperature melts like the paraffin wax that is what creates the magic bullet. So I think like, obviously I have a colostomy bag now, but when I did use one, the idea is I would put one in, make sure it's all the way in, and then I would wait like a good 10 minutes before I began any digital stimulation. And like when you go in there, you can feel if it's actually dissolved or not.
Can you become dependent on having to use that all the time, or no? Is it something you can use every so often?
That's Sue, go ahead.
That's controversial. I actually don't think you can become dependent on it. If you've got a neurogenic bowel, then you're going to need some help anyway. I think I like the idea of the half bullet, and I do believe the magic bullet is water soluble, so it melts faster.
Okay.
Hi, Sue. This is David Bevinger. I chatted that I'm an infectious disease doctor, and I guess I can take me off of video, put me on video.
Sure.
There we are. Hi. Yeah.
Hey.
Not the most attractive one on the screen, but here we are. So I just, I'm a quad, and I'm an infectious disease doctor. I can answer pretty adeptly at any question related to the microbiome for sure. But
Cool.
I just wanted to chime in about these issues. I think in reference to the suppository issue, we are dependent upon help. That's just the bottom line. So, I mean, if you're dependent upon a magic bullet, I mean, I'm not thinking there's going to be any shortage of magic bullets anytime soon. Should that happen, then maybe you'd have to wean off. But otherwise, it's 80 cents a day, or, I don't know how much you can get it for, 90 cents a day. And it's probably what you have to put up with. I have a lot of other thoughts. I'm as a quad, my sphincter is just shut tight. It's shut. So I don't have incontinence. It's just not an issue. But getting my bowels going was really difficult. Prior to my accident just over 2 years ago, I had extremely regular bowel movements. And so maybe psychologically, maybe physiologically, I wanted to have a daily bowel movement. And so that just made the most sense to me. And I do think being regular is appropriate for most people, and probably, in all things considered, the healthiest way to go. But I think that in order for me to do that, I found that unfortunately, I had to rely on milk and magnesia. So what I do is I titrate milk and magnesia. I try to have some solidish bowel movements at least every week. And almost every week I have at least, today was my diarrhea day. And it's really unfortunate. I don't think it's really that healthy, but reducing my bowel stress helped me so much. It really did. And so I would like to help anybody else think through these issues, because, as an infectious disease doctor, that is really what I enjoyed. A lot of my practice that I enjoyed doing was helping people think about their problems and their infections. And so if you want to chat with me, we can do it by phone, or if you want to email me, I'm happy to do it. But I just thought I'd put my somewhat unique knowledge base to serve for the rest of the group. So I think I've talked enough, but I am happy to talk more if someone would like me to talk more. Thanks again for everybody for this presentation.
Yeah, David, thank you so much. And David, if you want to connect with me about, providing more information or whatnot, please.
Yeah, sure. It would behoove me. It would be a real psychological boost to me to be able to do a presentation. I'm sure we could come up with some topics that
sure, let's
could be assistance.
David, let's connect.
Sure. Yeah, I left my email. Just reach out to me.
Great. I just want to acknowledge the time. It is after 12:30. So, but we did realize that this might go over, that people might have a lot of questions. So some of us are happy, myself, Susan, we're happy to stay on for a little bit longer. But we do want to thank you all for attending, and understand if you need to sign off, perfectly acceptable. And again, I will be sending out, this is recorded, will be on our YouTube channel, the chapter's YouTube channel, And anyone who attended, I'm happy to send you the all the slides as well. But please, I'm certainly fine staying a little bit longer if people have questions. I know that Edward has his hand raised, and I did see in the chat for you, Nicole, there's a lot of, there's some other information in there that people are sharing with you. And
Yes.
I do want to say, I know a lot of you do attend our support groups, and our support groups, you know, they're not just always for, I mean, they're wonderful for emotional support, but they're great places to ask questions like this and to hear what others are doing. Also, Susan Bergman attends many of our groups as well. She's a terrific support. And if you didn't catch at the beginning, Megan and Olivia, every Tuesday, we have a nutrition group every Tuesday at 12. So if you have a lunch break and you want to join, again, amazing resources that we have here for all of you. So please take advantage of those. But go ahead, Edward.
And also, I want to say we have, sorry.
You want to give a plug for the Spanish group, Maria?
Yeah, and also, yeah, we have a Spanish group at 2:30 every Wednesday. If you guys want to show up, you can. Dr. Susan is there with us, and she answers any question you like, because the Spanish group will also speak English there. If you want to join us, it's fine. We all learn from each other, and each people is different. And because everybody do their bowel care different, and everybody feel the different, and the spinal cord injury is different way to deal with. So if you want to enjoy and learn more, we're there for you.
Thank you, Maria.
You're welcome.
All right, Edward, you're up.
Okay, hi everyone. I'm a quadriplegic of 36 years. Dr. Bergman actually was my doctor back in 1985. Neither one of us wants to admit that because we would be that old. But I did want to say something to Nicole. It also could be something in his diet that's triggering this, something you wouldn't expect. I had problems with accidents all the time, and I made a food diary and just kept track of everything I ate. And eventually I figured it out that it was butter, as crazy as it sounds. If I ate anything with butter on it, no matter what my results were for previously, if I ate a meal and an hour later, I would have an accident if I had something with butter. And it turned out it was butter and sour cream, anything with a high fat content like that. It was just terrible. And it took me the longest time to figure it out. But now I have an accident once or twice a year, maybe, if that. You know, it's consistency and water and all those things that have been said all day. That's very true. But you might want to just check his diet and see if there's a common denominator in all this. Whenever he has an accident, there might be something that you say, aha, there it is, the trigger. It could be the exercise too.
Yeah.
It could be that, but check the diet too.
Well, yes. I admit that, so it's a blessing to have these, friends around a lot, the teenagers, but I do see, Wendy's, Burger King, I see rappers, and I know he knows he needs to be conscious of what he's eating, but he's a teenager, and that could be very well it. So I think it's a lot of us trying to figure out, priorities and what could happen if, he indulges. So I think that very well could be it too. One time a neighbor brought over, very well-meaning, a whole box of donuts for him and his friends and then that day, but for sure, it was there was an involved for sure first thing that morning when he got there. So I know, yeah, that's it too. But I guess, like you said, it was something as simple as butter. So there could be something like that too.
On the other hand, it's not much fun being a teenager if you can't eat pizza and donuts once in a while. But kind of knowing what it does, and then maybe saying, well, okay, maybe that means I need to leave a little extra time or, try to get it out before physical therapy.
Right. Start earlier. I'm really going to try to do that. Start a lot earlier. Give him more time in between when he gets there and see if we can do it again. Thank you guys. This was so helpful. It's easy. It's nice to be able to talk about it with people who can give me good advice. There's no one else I can really ask about this stuff. So thank you.
Or maybe you could do the routine after he does the physical therapy.
Yeah,
You
I
know,
was thinking
I don't think
about
you should be getting up at 5
Good
o'clock in
idea.
the morning to do this.
I know.
You know, it shouldn't be that complicated. I don't feel, you know,
Yeah,
maybe I'm wrong, but
I would
I
like
mean,
to
it has
find
to
a
make
better
sense
one.
for him and for you.
Mhm. Thank you.
Well, thank you everybody, because this is so great thing to talk about. Isn't a lot of people say it's nasty, but it's not, because it's what you eat is what you put it out. So I love to talk about this in my group. So I hope Heidi invited everyone to my group too.
Yeah.
Absolutely, Maria. Yeah, I think it comes up in all of the groups, definitely a topic in every group. If there aren't, and of course, if you think of a question, you know, later, or you want to connect with somebody, please let me know, and we can, you know, make sure, or if there's somebody that spoke, one of our panelists, if you want to connect with them, if you had questions, yeah, just reach out and let me know. And I'm happy to connect you. So yeah, thank you, everybody. This was great. Really wonderful. Thanks. So I think next month we're going to be talking about financial planning. That'll be our next series next month. So we'll go from poop to financial planning. So yeah, hope to see you all at our support groups throughout the week. Yeah.
Thank you, everyone.
All right.
Bye,
Thanks,
everyone.
Have a great
Bye.
day.
Thank you.
Nice to see everyone.
Thank you.
Thanks, everybody.
Thank you, Sue. And where did Megan and Olivia go? They're out of here.
They're still here?
I think they hopped off.